Hello again. So we're going to keep the cardiology theme going, talk about primary, secondary prevention of coronary artery disease. My disclosures have not changed since yesterday, still Amgen New Amsterdam, which, as I mentioned, I think today I'll just emphasize Amgen makes Repatha, so obviously somewhat relevant to today. I'm doing just a small investigator-initiated trial, so they're providing Repatha for that, and New Amsterdam is a drug that's not even on the market. Okay, so many of us have probably seen this graph before. When I was in medical school, we only had the white portion of the graph, and we were all obviously very happy and celebrating that over the past decades, cardiovascular mortality had been on the decline with the advent of statins, better revascularization strategies, better post-MI care. Unfortunately, right, most recent epi data shows that it's on the rise and actually pretty steeply going up, unfortunately. I can't say that many of us, unfortunately, were surprised, right? Because we've seen for the past 10 years, and then some, that obesity, diabetes, CKD, hypertension, a bunch of cardiometabolic disease has been on the rise. So this is just highlighting to all of us really the need for better prevention and detection of disease. So AHA came out with this a couple years ago, really thinking about the life's essential 8, right? These are all the things that are going to be critical in terms of addressing cardiovascular disease prevention in our patients. I'm very happy to hear that there's a lot of content this weekend on managing weight in particular. Given the recently published 2026 guidelines on hyperlipidemia management, we are going to focus a lot of that, the content today on that. But it's just important to think about that. There's a lot to comprehensive care of cardiovascular prevention. So just some high-level highlights to sort of just get us framed before we move forward. So one of the key things is that we have an earlier prevention emphasis with the new guidelines. Part of that comes from the fact that the PREVENT score starts at 30, whereas the pooled risk cohort equation started at 40, right? Because the idea is that we really need to start the ball rolling much earlier with our patients. And the PREVENT score for the younger patients does give you a 30-year risk prediction, right? Because for me, when I'm seeing a patient in clinic, doing a 10-year risk prediction in a 35-year-old doesn't really make any sense. So if I can calculate the 30-year risk prediction, then that ends up being more helpful for both of us. So now we're officially endorsing lipoprotein A for everyone, which makes me very happy. At ACC last year, not this year, there was a debate between the cardiologists in the room about who was for LPA and everyone who wasn't. I was very clearly in the LPA for everyone camp. The critique against it was that we don't have therapies for it yet. I mean, I'm going to emphasize yet, right? Because right now there's probably like 6 ongoing clinical trials for lipoprotein A reduction. And I do think there's a huge benefit in really better risk stratifying patients. For some reason, a lot of my patients don't care about LDL, but they're all very worried about their lipoprotein A. So whatever gets them, to converse with you about the risk, I think that's great. There's a lot more emphasis on risk enhancers. Reproductive risk markers. Now we officially have an algorithm for how to think about CAC scoring in the treatment plan. And then LDL targets have been reintroduced. I know it keeps going back and forth, right? We had them, we didn't have them, we have them again. I support this, and I think it's a little bit different. Before we were, okay, if you're at this level, we should start a statin. Now this is your risk profile, and we should target this LDL. And I think that makes way more sense for patients as well. And then we have like different tiers of targets based on the risk profile, including when you integrate CAC scoring. So learning objectives for today, right? So we're going to talk about screening for hyperlipidemia, strategies for hyperlipidemia management in high-risk populations, and then everybody else essentially, and then risk stratification tools that we're using with an emphasis on the PREVENT score. We'll talk a little bit about secondary prevention, which tends to be a little bit more straightforward, right? Because we're going to try to put everyone on a high-intensity statin and then some. And then we'll put a little bit more emphasis at the end in terms of really what are the different pharmacological, non-pharmacological options we have for patients. So screening for hyperlipidemia. So we have to start young. So we really need, they basically get 1 year pass once they turn adult, right? So once they're 19 years old, let's get a baseline lipid panel in them, and then thereafter we're going to check it every 5 years. And this comes a lot with the recognition there are a lot of people who have probably polygenic and heterozygous FH, it's definitely being under-screened, and there's really an opportunity, an honestly missed opportunity, to intervene earlier in some patients, especially since it's cumulative LDL exposure, right, that matters for atherogenesis. So I'm definitely seeing in my clinic, thankfully, younger and younger patients who are being sent to me with LDLs of 200s that were only discovered because their primary care doctors were appropriately getting lipid panels younger. For pediatricians or anyone who's family medicine, right, we were supposed to get a lipid panel in 9 to 11-year-olds to identify potential familial hypercholesterolemia or FH and other lipid disorders. Because again, there's an opportunity to find these folks a little bit earlier, and we shouldn't assume their parents have been screened, especially because we don't know what kind of medical exposure they had. And then it gets even younger if there's a confirmed history or really premature ASCVD. And then I really want to emphasize this slide, right? So the other day my mom called me and she's like, oh, because her primary care practice is not near her home. I have to drive here really early. I have to get there fasting, but I can't get there till 11 a.m. And I was just like, why are they telling you to get a fasting lipid panel? I mean, I didn't want to veto the provider's recommendation, but there's no need, right? So unless you're specifically know someone that has pretty significant hypertriglyceridemia, or you already got a fasting lipid panel and now you have to sort of rescreen them and figure out what's going on. Of course, if they're already going to come see you at 8 a.m., why not? You know, but I wouldn't make that a hurdle for patients. Ultimately, just get them in. They can get the lipid panel whenever, and we'll just get better uptake in getting these screening tests done. So let's just get on the same page about all the different lipid proteins, right? Because they all sort of do different things. And I think it's nice if we just go back a little bit to the basics and remind ourselves what each does, right? So HDL, or the good cholesterol, right? That transports cholesterol from the peripheral tissues back to the liver. And we think of it as an anti-inflammatory, antioxidant molecule. LDL is the opposite, right? Transports cholesterol to tissues. And this is really the villain, right? We know it gets deposited in our vasculature, and there it gets oxidized. And oxidized LDL is what starts the whole inflammatory atherogenesis cascade that triggers the foam cell formation, right? So everything. So we really want to minimize that. And for some of my patients who get very confused about the idea of cholesterol reduction, or for some reason worry about too much cholesterol reduction, I tell them, ultimately, we're not removing the cholesterol in your body. We're removing the floating cholesterol in your blood, and that's what we're trying to target. Triglycerides, as we know, are carried by VLDL and chylomicrons, and essentially as you remove the amount of triglycerides from VLDL, it becomes intermediate LDL and then LDL, right? So LDL is basically a lipoprotein that doesn't have much triglycerides. Lipoprotein A, as we, has gotten much more attention in the last couple of years, is an LDL-like particle, but it has more of a structure similar to plasminogen, and it tends to be more associated with prothrombotic risk. So definitely it's a different way to sort of categorize risk in patients that you don't fully capture with LDL. And then apolipoprotein B is a component of all these lipid molecules, obviously not the individual triglycerides. So every LDL particle has an ApoB, every HDL particle has an ApoB, every VLDL particle has an ApoB. And then in terms of screening for lipoprotein A, I mean, the answer is just check it in everybody, right? So the only thing that I don't know yet is, to what extent insurance companies have caught up with that, right? So it doesn't come up in my clinic because usually anyone who's referred to me has enough cardiovascular risk that justifies checking it, but I think we're still waiting to see if we're going to have any issues with getting coverage for this. But even if it's, once it gets elevated to 125, right, already you have 1.5-fold increased risk of cardiovascular events. So again, even if their LDL isn't elevated, this is an opportunity to sort of think about risk reduction in these patients. And then just always pay attention to the units, right? So the standard now is to use nanomoles per liter, but there's different units out there. So some of the older papers use the older units. So just keep that in mind because it does matter. For reference, in terms of like the clinical trials, right now we're only enrolling patients with 300 or greater. So they're really attracting higher risk patients.
If your board exams are in 2026 and you barely have time to study, do this question with me for 30 seconds.
Right now we're only enrolling patients with 300 or greater, so they're really attracting higher risk patients. So apolipoprotein B. First, let me sort of explain what ApoB is and why we think about it, right? So When we measure LDL-C, we're not actually measuring your LDL particles, right? We're measuring all the cholesterol, and then from that, we subtract HDL, because we can measure HDL. We subtract, then based on the number of triglycerides, we can sort of calculate how much VLDL we have. And then from that, we sort of infer what is LDL. So, and even the direct LDL measure doesn't actually measure LDL, right? It actually just measures all the cholesterol that we know is carried by LDL specifically, and then through some formula, we assume, okay, then that means you probably have this amount of LDL. The problem with that is that people have very different sizes of LDL particles, right? You could have a big LDL particle represented by this, little red car that's carrying a lot of cholesterol, and then you could have a small LDL particle that's carrying very little cholesterol. So you could actually end up having two people with the same exact LDL lab value, but they have totally different number of LDL particles. And this is particularly relevant in people who are hypertriglyceridemia, insulin resistance diabetes, where you might underestimate risk potentially in terms of just measuring LDL. So this is why the guidelines say the data isn't super strong, which is why none of these are class 1. But it makes sense that you could consider getting apolipoprotein B in these patients, particularly if you're already treating them. I think if you're not treating them, then it's sort of like the data's a little bit weaker, because then why are you checking it? And that can sort of help figure things out. In the secondary prevention cohort, I tend to check it when, they had a heart attack and their LDL was underwhelming. So I just want to make sure I'm not missing anything, and I check the ApoB. But yeah, I always usually focus this because I think I get a lot of questions, especially from patients, about ApoB. So in terms of just thinking about numbers, right? So you can think of the numbers pretty similar to LDL, right? So if you're going to target a treatment based on ApoB, then it's like a target of 90 if you're reaching for 100, and everything else ends up being pretty similar. Okay, so management in high-risk groups. So this is where I don't focus the prevent score yet, right? Because they're high risk enough that I'm just going to think about them very differently. So this is people with severe hypercholesterolemia that hasn't changed. It's still people with LDL 190 or higher. Familial hypercholesterolemia, which of course is going to overlap to some extent with severe hypercholesterolemia, diabetics, CKD, HIV patients. So severe hypercholesterolemia, it's really important that you exclude secondary causes, right? And then just make sure there aren't weird circumstances around the time that you're checking it. One of my best friends was a colleague at the hospital. Her lipids were checked when she was breastfeeding, and it was like all over the place. Turns out if you're breastfeeding, your lipid panels are going to be all over the place. So just keep that in mind. And of course, there's nephrotic syndrome. There's all these different causes. And basically, if it's 190 or higher, that equates to a very high lifetime risk of ASCVD. So in those patients, we definitely very enthusiastically want to start them on lipid-lowering medication. And ultimately, we're going to try to target an LDL less than 100 in them. And then if they have FH and already have some plaque formation, we're going to target an LDL of 70. And then the bottom, we're just listing some of the other things you can do to rule out secondary causes like hypothyroidism, right, steroids, and all that stuff. And then the ketogenic high saturated fat diet is not something I thought about very much, but I'm not sure. I'm sure maybe your patients have brought it up, but there's like all this social media about the carnivore diet and all this stuff about needing to have more fat in our diet. So it's unfortunate because it's definitely not based on real evidence. And one of my good friends from college who's not in medicine, I found out was doing that. So it's definitely getting out there to even highly educated people, and we just have to be very careful about that. There is a risk score for people who are interested that sort of predicts the probability of someone with very elevated LDL. What are the chances they have FH? It's just so you know, when you go to the website, you'll just have to convert it to the American units because they use sort of the metric units for LDL calculation. But it's stuff that makes sense, right? So do they have a first degree relative with it, right? Do they have early onset ASCVD? Do they have physical signs of cholesterol deposits, all that stuff? And based on that scoring system, you can sort of figure out if they have FH. But most of the time, if they're young and have an LDL of 200s, I mean, I basically tell my patients, you almost certainly have heterozygous, if not polygenic FH. So the guidelines do definitely say it's definitely class 1 indication to test if there's a pretty high suspicion for FH, and a little bit weaker evidence if the LDL is only slightly elevated and no first degree relative. A little bit weaker evidence if the LDL is only slightly elevated and no first degree relative. And the LDL, sorry, it's not as quite as high. I would say that in my practice, I don't actually do genetic testing for this very often because it's not really going to change my management. There are very few mutations that make them not really respond to statins and standard therapies. And I have a tool that I can do to screen the relatives. I just get a lipid panel and their relatives. So it's certainly an option, and some patients are very enthusiastic about wanting genetic testing, but I tend to see a pretty low socioeconomic population where it's not always guaranteed that we're going to get coverage for it. And again, it's not really going to change management in most cases. And the risk, attributable risk to FH obviously is huge, right? So in some cohorts, it gives you an increased risk of 2 to 4 times compared to what the traditional risk scores calculate, up to 17 times in younger adults. So we don't use the PREVENT score, the pooled risk cohort equation, right, in people with confirmed FH or suspected FH. And then obviously, please refer these folks to a specialist. It could be a prevention clinic, it could be a lipid specialist, it could be a general cardiologist, so we can sort of really start doing more aggressive risk modification with them. And then the guidelines do endorse using non-statin medications in this population, which is often necessary, right? If a statin at its best is going to reduce LDL by 50 to 60%, and they have an LDL of 220, you're just not going to reach target LDL on one agent alone. So what about diabetes without ASCVD, right? So this isn't that different from the previous guidelines. The diabetes is enough of a high risk for ASCVD that we're going to recommend a statin in these patients, at least a moderate intensity statin with a target LDL less than 100. And we obviously can use the other agents, class 1 recommendation, if there's statin intolerance or they don't tolerate higher dose statins. And then everything else is a little bit of weaker evidence for using the other agents only because we don't have the trial data in primary prevention to the same extent we do in the secondary prevention population. And adults with chronic kidney disease, this has got more emphasis in these guidelines. I mean, I think we've all seen that kidney disease has gotten a lot more attention, especially in the last 2 years. So similar to diabetes, we think of it as a pretty high risk factor. So sort of a similar idea, right? If they're in that age group, they have CKD, we should put them on a statin and pretty much target them the same way. And obviously feel free to use ezetimibe in these folks for additional risk reduction. And then adults with HIV, right? It's a chronic inflammatory condition, even if their HIV levels are appropriately suppressed. So we do recommend treating these folks for risk reduction. Just keep in mind that their antiretrovirals have a lot of drug interactions. Even if I look it up, checkondrugs.com, I will always email someone's HIV specialist before I change or start a new medication, just to make sure we're all on the same page. I was humbled a couple weeks ago when a long-term patient of mine, since I've been following since I was an intern actually, had postnasal drip, and I prescribed her Flonase, and I was like, oh, I mean, it's not systemically absorbed, right? Apparently, there's case reports of getting Addison's with Flonase in HIV patients on the antiretrovirals that she was on, so it just reiterated like the lesson to me, always definitely be in close communication with their HIV specialist. Pitavastatin is a very common one we use just because it tends to not interact, but again, you have to double check with them. Okay, so what about patients without atherosclerosis or ASCVD and then are not part of those high-risk groups? So this is where the PREVENT score helps us, right? So I have a table here just to sort of give us a sense of what the percentages are like in the new PREVENT equation versus the pooled cohort equation, right? So whereas high risk before was 20% or greater, that's 10% now. The borderline risk, which tends to be the group that gets the most attention, because that's the one where you can go either way with lipid lowering, that's 3 to less than 5% in this group. A lot of the risk factors are the same that go into the equation. We just took out race, right? Which has been the theme for a lot of formulas in medical practice. We're just really taking race out of a lot of things. We added hemoglobin A1C, we added urine protein. There is a zip code as well to think about socioeconomic risk factors, right? So those are all the optional add-ons, but a lot of the things are the same. And obviously that's now the endorsed calculation. It does technically compared to the old cohort equation, which was based on the Framingham cohort and two other cohorts, we really just needed an updated population, right? The Framingham population is really from or older than the 1980s, and our folks today look quite differently. They're not smoking as much, right? They have more cardiometabolic disease. So it's thought that the old equation tended to overestimate risk, and the current equation does a little bit better. And some people think that it results in less statin initiation, but it could go either way, because you might get less risk prediction with this one, but there's so much more risk modifiers and much more CAC integration that it could end up actually being more statin initiation for some people. More statin initiation for some people. Okay, so how do we think about this, right? So you're going to do the prevent risk score. You get someone with low risk, which is great, right? And then we're just going to really focus on lifestyle modification if their LDL is less than 160, right? Because once they're over 160, they're a little bit of a higher risk group. And at the borderline risk, this is where we really want to look at our risk enhancers and think about, is there anything that you have? Did you have preeclampsia and pregnancy? Do you have lupus? Do you have psoriasis? Did you receive some oncological treatment that increases your risk of ACVD? So this is going to be an opportunity to have a conversation with the patient about, should we actually put you on a lipid-lowering medication? And a CAC score can be done, and now we have a class 1 indication for the CAC score where it was a class 2 before. Anyone who's going to be intermediate and high risk, we're putting them on a statin, essentially, right? So, and I know there's still a lot of inertia sometimes in our patients to start lipid-lowering therapies, but I think you can definitely still get a CAC score in the intermediate risk if there's still some friction there. And high risk, we should just be putting everyone on that. And we don't obviously discourage lifestyle modification. When I tell my patients, it's like, okay, this is your menu. This is your menu of all the things that will, reduce your risk of having a heart attack, of dying, heart failure, or stroke, right? So are you telling me you only want 2 of the 4 things, right, on the menu that are going to actually tackle these things, right? So I think it's really important that we frame it. It's like we really need to just do everything that's possible to reduce risk. And this is sort of like a very easy table that I created, so it could be easy to reference who are all the patients that we do recommend statins in and the level of evidence, right? So in low risk, if you have an LDL of 160 or greater, not the 190, because at that point, obviously, you're the high-risk group, then we start a statin, 2A level evidence, target less than 100. If you have an elevated risk score in that population, 30-year risk score, right, then that would also be a reasonable target of less than 100 in that population as well. Borderline, moderate intensity statin, similar to the other one, intermediate. Now we get to level 1 evidence, target less than 100. And then the high-risk group, we want a high-intensity statin, right? It's fine if they want to start lower because they're unsure about going straight from a high-intensity statin. I do remind my patients that I start people on high-intensity statins from the get-go when they're hospitalized for an MI, so there's no reason why biologically they can't handle a high-intensity statin either. But for folks who want to start with the training wheel dose, we'll do it and then have a very concrete plan at 8 weeks to reassess and increase the dose if they're not at target less than 70. And then obviously we can use some of the other medications to reach that target dose. So what are the risk enhancers, right? So there's a whole constellation of them, and we definitely want to think about family history, particularly premature ASCVD. And that one tends to work pretty well in terms of for patients. I think if they have a family member, particularly a parent, that had an early MI or died from an MI, then they're usually very motivated to intervene. There are certain ancestries, particularly if you're of South Asian or Filipino, that is associated with higher risk of ASCVD. The polygenic risk score is becoming more common now, variable insurance coverage, but I am starting to get patients where their doctors have ordered the polygenic risk score and it comes back as high risk, and then they basically get referred to me to evaluate them for it. And then a couple patients who've actually requested we do it to sort of decide what to do. It does perform really well. It's just, it's going to take, I think, time to figure out what do we do on a more mass level with this data, right? Chronic inflammatory disease is huge, right? So I think sometimes we underestimate how much having rheumatoid arthritis, even psoriasis, right? There's like a bunch of papers now published that all these things are associated with increased risk of MACE. So we definitely want to target ASCVD risk reduction in these people. An elevated lipoprotein A, elevated CRP, right? CKM syndrome, which we've always known, but now we have a new brand attached to that condition. And then reproductive risk markers. And I want to emphasize that particularly because, so my clinic dot phrase has this. Like, I will screen everyone in my clinic for age of menses, menopause, did they have preeclampsia, gestational diabetes, hypertension during pregnancy, because all these things we know increase the risk of having cardiovascular disease. And then menopause in particularly is important, right? Because if they start menopause much earlier, under 45, that also is associated with increased risk of events. And I'm starting to see now also more counseling related to MHT, right? Because HRT is out, that's an antiquated term. Now we say MHT, menopause hormonal therapy. And more patients are asking about it. There's more social media around this topic. The guidelines are not quite, there's no published official guidelines, but there are published statements on how to think about this. But generally, anyone who's going to be high risk, I tell them I don't recommend MHT. So in terms of older adults, I think this is a really important question. So it's funny because we think of elderly as 75, and I would say probably the average age of my patient in clinic is 80. So I don't even think of 75-year-olds as being old. They're like on the younger side in my patient panel. And so many of them are doing so much, and I expect them to have at least 5 or 10 more years life expectancy. So I definitely don't ever think about someone who's like 78 as you shouldn't get a statin. But I do definitely stop to think about, okay, does it make sense in that person, right? Are they particularly frail? Do they have are they ESRD? Do they have some particular malignancy? So I do factor in all these things. But at the end of the day, once people get to 70s, 80s, I've noticed that a lot of them are very highly preoccupied with dementia and strokes. So when we have that conversation, I mean, one of the few tools that we have to sort of prevent that are lipid-lowering medications. So again, you have to customize the plan for each individual. And sometimes you're actually having the conversation with their loved one, right? And not necessarily just the patient. But we should not basically just say, okay, you're 78-year-old, you don't need a statin, right? That's basically what we're trying to say. Don't dismiss it just because of their elderly. And the good news is we don't think as a field anyone's doing this, but it's more so to have that conversation with our patients. And some of them still think statins are associated with dementia. So I keep reminding them that no, actually vascular dementia is becoming increasingly common. So actually statins help with addressing that kind of dementia.
A custom sign for all your needs. Laminated labels, magnetic, plastic, and aluminum.
Common, so actually statins help with addressing that kind of dementia. So what about available CAC data, right? So that is something that's gotten a lot more attention, which I'm very happy about. And there's a lot of more guidance around that, right? So let's say we do get a CAC score. Either we intentionally did because there was a little bit of equipoise or ambivalence about the statin, or by the time they get to your clinic, as in my case, they already have a CAC score. So if they have a mild amount of CAC, which is less than 100 basically, then at that point they have plaque. And I do consider starting a moderate intensity statin in those folks, and I'm going to target an LDL less than 100. If they have a moderate amount of plaque, which is 100 to 299, then I'm certainly going to start LDL lowering therapy. The reason it changes to LDL lowering, because now the guidelines there are actually recommending statin, PCSK9, ezetimibe, whatever you need, basically to target LDL lowering. Because now it's not, it's subclinical CED, right? So it's not exactly the same thing as everybody else. And again, we're going to target an LDL now, ideally less than 70, because they have a pretty decent amount of plaque burden. A severe amount of CAC, right? There's been many studies now that have shown that in terms of risk of MACE events, people with severe CAC actually have the same risk of MACE as someone who already had an MI. So I tell my folks with severe amount of CAC that I'm going to treat you as aggressively as my patients who already had a heart attack. And then in those folks, you can even look at ApoB to make sure you're really comprehensively, accurately reducing their risk. What about extensive CAC? And this I really do appreciate because I thought it was always a little bit ridiculous that I would be targeting the same thing in my person who has a CAC of 301 as my patients who have a CAC of like 2,300. That doesn't make any sense. So we do have a separate category for them now. And as you can see, the LDL target with them is the same thing as a high-risk secondary prevention patient of 55 or less. And then what about incidental CAC on non-gated CTs, right? So if someone has a lung cancer screening CT, so non-contrast CTs are the best. It's a little bit tougher to see the CAC when you have contrast going into the arteries. So CTP, CTAs are tough, and the radiologist will make an estimation, but it's hard. So in the report, they are supposed to put it in there. If you're not comfortable scrolling through and looking for the CAC, they'll say if there's a mild, moderate, severe amount of CAC. But if you just scroll through and just look at it on the regular horizontal axis, you'll just see, right? Because at the end of the day, a normal heart shouldn't have anything the color of bone. So even for my med students, I'm like, just scroll and just keep going until you see white stuff just pop out on the screen, right? And all of a sudden you'll see dense calcium, just like, here, go back here, right? So normally it should be shades of gray in the heart. You shouldn't see all that white stuff, and that's all in the left main and the left anterior artery. So, and many studies have shown that the CAC that we see qualitatively correlates really well with the absolute quantification of the calcium score. So I don't get calcium scores if I already have a non-gated CT chest. I just think that's a waste of resources. So, but I will treat it the same way. The reason it just has a weaker level of evidence is just because obviously most of the data published is around formal CAC scoring, not incidental CT data, but there's a lot more recent data being published on that front. Okay, so what about high triglycerides? So it's important to think about the level of triglyceridemia and what you're trying to target, right? So when someone has, significantly elevated triglycerides at 500 or greater, right? It's not so much that I'm worried about ASCVD risk, even though obviously they do have ASCVD risk, but my concern there is pancreatitis, right? I'm gonna give them fibrates or Vascepa, but mostly fibrates, and treat secondary causes, particularly insulin resistance or diabetes, right? To reduce the risk of pancreatitis. I'm not thinking, oh, this fibrate's gonna prevent a heart attack. No, I have never in my life prescribed a fibrate to think I'm actually addressing ASCVD risk score. So for significant, moderate to severely elevated hypertriglyceremias, we do wanna treat that. We do use the prevent score. We do still use a statin, right? Because all these things are gonna help tackle that, and whatever left over, we just have to think about what else we can do. And then there's like familial hypercholesteremia. That's very complicated. Even I don't see those patients. I sent them over to our prevention clinic, because then they have to be considered for really much higher level medications for that are almost some of the monoclonal antibody medications. So what about everybody else who just has run-of-the-mill elevated, triglycerides? So lifestyle intervention is obviously what we first recommend, because if we change the amount of sugar intake, reduce alcohol, again, huge. I know I stressed alcohol intake yesterday. I'm going to re-stress it today. If we really reduce their saturated fat intake, often that will be enough, and they don't need to be put on a medication. I find it really hard to get coverage for Vascepa in primary prevention. Honestly, I find it tough to even get it covered in secondary prevention populations. But also, I'm not super eager, like I said, to start fibrates in these folks, because there's no data to support it for ASCVD prevention. And then for over-the-counter fish oil pills, omega pills, I don't personally prescribe them, right? Because there's no data to support its use. If you think about, you'd have to take like 15 pills of fish oil to get the same EPA equivalent that's in Vascepa. And even then, it's still not the same thing because then you have the potential downsides of all the other contaminants and the other substances that are in fish oil pills. So there are like other uses for fish oil pills. I know the OB community recommends it during pregnancy. I have one patient who told me that it helps with joint pain. So I learned that day. But I definitely don't prescribe it for the purposes of ASCVD risk prevention. Okay, so what about managing in patients with actual ASCVD? So this is where we are a little bit different than ESC, the European guidelines. We still sort of fixated on this idea that we have to differentiate people as very high risk versus regular high risk. I find it a little bit amusing. When someone has had a heart attack or stroke, I just think of everyone as being pretty high risk. But the point is, obviously, if and almost everyone I see in clinic is going to be over 65, has had some revascularization, right, is a diabetic. So almost everyone meets this criteria. But the idea is you're going to really target LDL of 55 or less in these people, not just simply 70.
In 5 years, I think you'll see these on the back of almost every phone in the room. There have been so many calls
in these people, not just simply 70. And so not very high risk is 70, but technically you should 55 to a recommendation, or very high risk less than 55. And like I said, I just do 55 in everybody. And the ESC guidelines also just target 55 in everyone who's had a prior ASCVD event. And then at this point, right, you have the full menu of items with stronger class recommendations for this population, right? So generally, we will try to do the maximal statin tolerated. If they have an LDL, you know, in the 160s or higher, they're almost certainly going to need 2 medications, right? Which is why the guidelines also agree that for people with particularly high LDLs, when you discharge them from the hospital, just already do the statin and the ezetimibe together, since there's no downsides to that, and it gets them to the goal LDL a lot sooner. The Repatha does end up being for sure easier in the outpatient setting, unless your inpatient team has pharmacy support, which is highly variable by institution. But this is something that's very routine now. I do not have any issues getting it covered anymore. I think when I first started practicing, yes, but now anytime someone has CAD, it just gets covered. So the only thing that might change is depending on their Medicare Part B coverage, right? How much the patient has to pay might be a little bit different. So I usually will stick to those, statins, ezetimibe, PCSK9 inhibitors, and then only if I run into issues might I reach for bempedoic acid. I've yet to actually prescribe inclisiran because most of my patients are fine with just the once every 2-week injections from a PCSK9 inhibitor. So in terms of managing hypertriglyceridemia in ASCVD risk patients, right? So this is where the data exists, right? We don't really have a lot of prevention data with Vascepa. So the trial that was published a couple years ago did look at everyone with 150 or higher, and then we did see about like a 5% absolute risk reduction in those folks. And this is again with the highly purified form of EPA. But again, we really still want to target secondary contributors from the very beginning, because I think that's a missed opportunity if we just go straight to trying to give another medication in folks, if we could potentially target them by just eliminating alcohol. And I have found that post-MI patients are a very motivated group, so we should definitely take advantage of that and come up with a plan. And cardiac rehab is obviously great for that reason too, because they sort of go through a lot of this with them. And again, it's a 2B recommendation to consider icosapent ethyl or Vascepa, because there's been a lot of controversy around that medication, right? And a lot of it stems from the fact that the control group was a mineral oil pill. And a lot of people in the hyperlipidemia community feel, well, a mineral oil pill is not an inert substance, and could it be that we made the control group be a relatively higher risk than the Vascepa group? So it's still, you know, there's data saying maybe it's not as great. I'm on the fence in terms about it. But most of the time, I think with a lot of risk factor modification, we're able to actually control a lot of people's triglyceride levels. Okay, so lipid-lowering medications. So there are a lot of things folks can do, right? And if they're still having a huge intake, or a significant intake, I should say, of saturated fat, trans fat, poor fiber, then they can actually make a decent dent in their cholesterol. A lot of my patients, though, to be honest, are eating better than I am. They're really good about avoiding the red meat. They're having a lot of plant-based foods. They haven't necessarily gone vegan, but they make a point to really have a lot of plant-based in their diet. They've reduced simple carbohydrates. For a lot of those patients, I tell them, like, you're probably gonna make maybe a 10–50% reduction in your LDL, right? So on average, when you take like just the population as a whole and you do dietary modifications, you reduce LDL by 25%. So I think that's important to think about, not because we don't want people doing that, but we have to be realistic of what's feasible. So if their LDL is 160, there's no way they're gonna get there unless they're like literally eating, burgers every day. Their LDL is gonna get to 55 or less if that's their target with just dietary factors, right? So in my primary prevention folks, I might, agree to a stage approach where, fine, let's do this, and then we'll circle back, and then we'll add the statin later. In my secondary prevention group, we're like, no, we're doing everything. You do that, I'll start the statin, and then we'll meet, 8 weeks from now and see where things are at. And then in terms of triglyceride levels, right? So this is where weight loss actually has a huge effect, and part of that comes from insulin resistance, right? So as we lose weight, our metabolism for triglycerides improves, insulin works better, so then triglyceride levels improve significantly in that setting.
This is going to be hard truth for some of you to swallow, but the learning does not stop once you become an attending. I'm so sorry. Board exams and
so then triglyceride levels improve significantly in that setting, and physical activity as well. There's things we can do for HDL, but again, this is a little bit of an antiquated figure from 2011. Most of the time, a lot of the reasons HDL goes down, some of it are in our control. So again, alcohol will reduce your HDL, poor exercise. A lot of time it's just gonna be time, right? So a lot of my female patients unfortunately get very, discouraged sometimes at the menopausal transition because they see their lipid profile just look totally different, within a couple years. But again, I use it as an opportunity to sort of have a conversation with them. Okay, you can't control the fact that your hormonal profile is different now, but we can definitely tackle some of your other risk factors. And then please don't forget about pregnancy and lactation, right? So I'm seeing a lot more younger folks in my clinic, and sadly a lot more premature CAD in women. This past year alone, so many women who've had first heart attacks in their 30s and their 40s. So I'm having to think about this a lot more, or even in my folks with at high risk, right? And I have to really stop and remind myself, like, wait, are you trying to have a baby? Are you gonna have a baby in the next couple of years? And we have to think about that a little bit, right? In terms of, I have one patient who has, her LDL isn't very high, but she has a really strong family history of premature CAD. So we've decided that, we'll have her on a statin right now because she's not actively trying to have a child, but once she starts, we're gonna definitely have her come off of it. The guidelines do say it's reasonable to continue it if someone's particularly high risk, but I've yet to find a mother, who wants to stand it because of, the lack of data around, what could happen to the baby, right? So I think it's probably safe, but I've never met a mother same, right? Like, no, let's just, stop it during pregnancy. So, but it is an option for people who are particularly concerned about their cardiovascular risk. And then this is the table, right, of the statins, right? So again, the only high-intensity statins are Atorva and Rasuva. Those also, not coincidentally, are the only ones I prescribe, right? Other than like occasionally pitavastatin because of my HIV patients. I detest simvastatin. It's like very commonly prescribed. It tended to be very popular. I hate it. There's a lot of drug-drug interactions with a lot of other cardiac medications. It also tends to be more associated with myalgias. So I never prescribe simvastatin. But again, it tends to be more my patient demographic, right? So my patient demographic tends to have a lot of other cardiac medications, so then I'm gonna have more issues with drug interactions. I think in the primary care population, it's less of an issue, but I have yet to meet a cardiologist that prescribes simvastatin. So I'm gonna go high intensity, and use lower doses of those if needed. Rosuva is the only one that in the clinical trials did not actually have higher rate of myalgias compared to placebo. It doesn't mean your patient won't have it, but it helps it as a selling point. Rosuvastatin is also what I take myself. So it tends to come in smaller pills than atorvastatin. For some reason, some of the generic providers of atorva make these horse pills for the 80 milligrams. So either you can have them, cut it, take the 40, but often I'll just switch them over to Rosuva for that reason. And then occasionally I have used, pravastatin if someone is thankfully really gung-ho about still trying a statin and we've failed atorva, we failed Rosuva. These days, I often, at that point, if they failed 3 statins, I'm just going to try to go for a PCSK9 inhibitor if it makes sense for that risk profile. And of course, please don't be prescribing Simba 80. That's not a thing. We actively discourage it. So statin intolerance, it is real, right? So I do think it's real. I don't think every case of aches is statin related, but I do think in some cases it very much is related to a statin, especially if you have a clear temporal association. The hard part is a lot of our patients who are 60 or older have many reasons to have aches and pains, right? So we just have to be very mindful of that. If we stop the statin and a month later they're still having aches and pains, it's probably not related to their statin, right? Because in the studies that have been published, most people, like over 80%, have complete resolution of their symptoms by then. So one of my patients who, it was Rosuva, clearly they started having leg cramps at night, exactly a couple days after I started it, and I stopped it, and within 2 weeks, those symptoms completely went away. So I believed it, and we're gonna try to see if he tolerates a different statin. And then usually, again, try a couple others, and it's okay if you don't end up taking a high intensity statin. Any statin is better, because to this day, right, we haven't proven that PCSK9 inhibitors and the other medications have the same pleiotropic benefits that statins do, right? Statin is anti-inflammatory, it's not just LDL reduction. So I say, any dose is better than no dose. And if they really tolerate nothing, then we're gonna move on to the other is better than no dose. And if they really tolerate nothing, then we're gonna move on to the other ezetimibe, which in general, almost everyone tolerates ezetimibe. It can cause some GI disturbance, which is really uncommon. Usually if that happens, is someone probably already with a substrate of just not tolerating and having GI side effects of medications. PCSK9 inhibitors, we'll get to in a second. Okay, so what about screening for adverse effects, right? We don't recommend just getting a CPK in everybody in the absence of a clinical reason for doing so. We don't recommend getting LFTs just for the sake of doing so. And then, there's no data with coenzyme Q10, but I'll say if for whatever reason it makes that patient take it and tolerate it, by all means, right? There's no harm to it, but it's not something that we're gonna formally endorse as actually, helping patients because the data doesn't exist. So in terms of ezetimibe, right, the data exists primarily in the secondary prevention cohort, not so much primary prevention. We know it reduces LDL by up to 25%, right? So pretty similar actually to dietary, which is not surprising, right? Because ezetimibe reduces cholesterol absorption from your gut. So it's just funny that it works out actually, being the exact same number. So in the actual trial, they use Simva 40, so moderate intensity statin, with that in addition to ezetimibe in post-ACS patients, so it was a very high-risk group. And we saw 6% relative risk reduction, 2% absolute risk reduction. And yes, of course, these numbers are small because, again, these are already people on maximally tolerated statins, right? So this definitely tends to be my second-line medication. Most insurance companies also require you have tried ezetimibe before they even will approve a PCSK9 inhibitor. And then PCSK9 inhibitors, so the two routinely prescribed that are on the market are evolocumab and alirocumab, right? They both have high quality, 15,000 plus clinical trials showing reduction of MACE and all-cause mortality, right? So they had 20% relative risk reduction, 2% absolute reduction in CV, death, stroke, and MI. They're very well tolerated. I have, my renal transplant patients, my cardio-oncology patients, my rheumatological patients who all take complicated medications. It works with everything, which is kind of nice. And then my patients who don't tolerate any medication somehow tolerate these medications. So the one thing I do just prepare patients is that there's this theoretical runny nose they can get for a day. I just let them know that, but and then a couple patients will say, oh yeah, I remember when I injected for like a day, I feel like that feeling before I'm gonna get a cold, but I never get a cold, right? So sometimes it's just nice to like give them something, and then they'll see that it's not a big deal, right? The side effect they're going to get. And then make sure you coach them on the injection, especially these days. I don't have to coach as much, just, everyone's getting prescribed GLP-1 injectables, it seems like. And I'm definitely prescribing those routinely. So I don't have to coach as much as I used to for these medications, but both both pharmaceutical companies make amazing patient-friendly videos and in Spanish as well about how to inject the medication. And just remember to always double check. I just found out the other day, it wasn't these medications, it was a GLP-1 that wasn't working, and I found that they were injecting their buttocks, right? So just make sure they're actually injecting the right spot. And then it's usually once every 2 weeks, which even for the most like nervous patients with these getting the pens, they usually are agreeable to doing once every 2 weeks. Okay, bempedoic acid is sort of going to be the one after all of those medications. It also can reduce cholesterol about like 20% in some folks. The main thing is to be careful because it can worsen gout flares, it can increase creatinine in some people. And there's this unclear reported, incidence of tendon rupture that's still being investigated, but certainly something available for folks, especially if they're very statin intolerant and can't tolerate the other medications. We already talked about purified EPA, so I'll skip this for now, but it's the idea of having a highly purified EPA substance. Okay, so what are the take-home messages? Treat dyslipidemia earlier to reduce lifetime risk of prolonged exposure to atherogenic lipoproteins. Use now the PREVENT score, and like I said yesterday, it's coming to a lot of EMRs soon. Maybe some of you already have it, I don't know, we don't have it yet. So it's coming. And then we can do 10-year and 30-year risk assessment. Again, I reserve the 30-year ones for my younger patients, and it's meant for people who are 30 to 79. Use risk enhancers and CAC to refine those risk estimates. And then LDL lowering therapy can be considered in adults.
Quiero hablarles del kit limpieza.
And then LDL lowering therapy can be considered in adults for primary prevention of ASCVD with a 10-year risk score estimate of 3% or greater. And then ApoB, right, can be useful to improve risk assessment and guide therapy once LDL and non-HDL goals are met. And then lipoprotein should be now measured at least once in everyone. And generally, we just right now measure it once. There's no consensus on when we should be rechecking it necessarily. Some people think every like 10 years or something. And then LDL lowering therapy is recommended for primary prevention adults who have CKD, diabetes, HIV, regardless of baseline LDL level. And then for secondary prevention, just shoot for 55 for everybody. Okay, perfect. Questions?
So for patients who come in at some where their parents who have premature disease, or they're like every single uncle and dad, mom has disease, but they're a 32-year-old average male, maybe overweight, obese, how do you approach those patients, like in terms of automatic statin, do you do CAC score, do you do stress test, or anything like that?
No, it's a good question. And yeah, I have my own mic. I think it just depends on, well, first of all, what is their LDL, right? So if their LDL is 160 or higher, then we're going to do everything, right? And that demographic, and we're going to check a lipoprotein A and those folks. For LDLs that are sort of like 111, right? The thing where it's like not pristine but not super high, then we just have a conversation. It's like I say, I'm a little bit nervous about your family history. There's something that you might have inherited from them that you cannot control. So let's talk about what you can control. Then I'll sort of list all the things that you have listed. I generally will encourage initiation of a lipid-lowering medication, and only if if they're sort of on the fence or aren't sure, then I will consider a CAC score or something else. The problem is I don't love CAC scores in people under 40. I think if they have a really strong family history, I'll still do it because something clearly is causing plaque formation earlier on. But the thing to keep in mind with a CAC score, right, it's calcified plaque, not non-calcified plaque. So you are going to potentially underestimate plaque formation in them. But again, it's really unusual for someone to have an MI and have like 0 plaque. And I tell them in their case, the only number that would make me feel comfortable in them to potentially defer is a CAC score of 0. It has to be 0. It can't be 5, it can't be 10, it can't be 30, right? And then that, if I'm upfront with them about that, that's usually a little bit easier. But yeah, I tend to be very pro. I think I'm definitely more on the aggressive front when it comes to treatment. I usually will only do baby aspirin if they have at least moderate plaque. And then for sure, severe amount of plaque, moderate depending on those other risk profiles. I never use it for mild amount of plaque. Yes.
You mentioned about contrast CTs and CAC scores. I do see that more often now. And I was wondering, because the guidelines all talk about non-contrast, but how do you deal with the contrast CT and the radiologist guess?
Yeah, I mean, it helps. It's more that I don't know if I'm seeing all of it. But if I see already a decent amount of it, I'm sort of done, right? So, because sometimes I'll see that I could see the specs, and I'm like, okay, there's definitely at least a moderate amount of plaque. And that's sort of what they're doing too. They can't technically see the full extent of the plaque if some of the contrast is floating through. They're gonna, so the only risk you have is potentially underestimating plaque. So, but if it says moderate, then it's moderate plus. If they say severe, then you're done, right? So that's the only thing to keep in mind. Yeah. So usually we say every 5 years if that's the case, right? And again, this is for someone who's untreated, right? Because statins calcify your existing plaque. So no one should be getting serial CAC scores if you're actually treating their plaque, because we are intentionally putting them on a medication that's going to take unstable, uncalcified plaque and turn it into stable, calcified plaque. So I've had referrals where like, oh no, my CAC score went up after I got a statin. I'm like, yes, that was always going to happen. But if they stay untreated based on their CAC score, then we usually say you have this like 5-year window for that. Mm-hmm.
Is there such a thing as too low of LDL, like a subphysiological level?
No, no.
Like I had a patient that came in, their LDL was 10.
That's great. Yeah, fine. I mean, what I would say in that person, just look at what they're on, because if they're still on that ezetimibe and you want to sort of, and they're really eager to simplify their regimen, I'll say like, what is that ezetimibe doing? We could probably just leave you on the statin and the PCSK9 inhibitor. But the studies right, TIMI has done a pretty good job at showing in their trials that people who got below 30 still had increased reduction of MACE with no adverse effects. So the cardiology community very firmly believes there's no level too low. Because again, I remind patients, this is not your total body cholesterol. This is your free-floating LDL levels. And the data that exists about observational stuff, you can't use that, right? Because when I look at people who have naturally low LDLs, those are like my end-stage cancer or ESRD patients. That has more to do with sort of like their amount of like lean body fat and all that stuff, right? So I would say I don't think you need to shoot for 10, right? But if they're there after a statin and a PCSK inhibitor, I wouldn't necessarily de-escalate purely for that purpose. Yeah, if you're going to treat it and start a statin, you're done, right? If the LDL is elevated and they already meet criteria and the patient's willing to get started on a statin, I don't really see the point of checking ApoB. I do check a lipoprotein A just because it gives me a different risk profile than LDL, right? So if their LDL is 105 and I'm going to target an LDL of 70 because of the risk profile, but then their lipoprotein A is 300, right? That's a huge, huge score. So then I'm going to think about, okay, you're at higher risk, so it just changes the conversation of how much I feel comfortable pushing patients. And again, it gives you a better chance to also just get them a little bit more on board with some of the risk reduction. Yes, I don't know yet what's going to happen with the LPA reduction trial, so we're going to learn from that. But I do think it's just always important to think of what's going to give you different information. ApoB, I rarely check, to be honest, because it really needs to be someone where there's something I'm not getting from the LDL, or the LDL doesn't make any sense, right? And I think I'm not actually appropriately targeting the right LDL.
Customize your message with ease. One sign,
Well, it matters for family members, right? So LPA is more genetically determined than LDL. So if you have a high lipoprotein A, I make sure every first-degree family member gets screened. And then, right, lipoprotein A is more associated with acute plaque rupture, thrombotic events, right? So then I might, if I'm on the fence about an aspirin, maybe I'll choose the aspirin more in that patient, right? So it just, again, it's just a different round the clock. It's not purely just for LDL reduction, right? It's just making me think about that person, like what else can I be doing in you? And I tend to be more aggressive. I become like, my patients always call me like the nice bully, right? So if I see just more on the table in front of me that we have to combat, then it just allows me to sort of really push them a little bit harder. But you're right, from a purely LDL reduction level, it's not, may not necessarily change very much. Yes.
So if I understood correctly, if you have somebody with family history and their LDL is 85, and you say, well, then you can check ApoB, and if it's sky high, then you try the studies.
Yes.
And you target with ApoB.
Yes. Correct. Correct. Yes. 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 So in the case where the LDL doesn't match, the discrepancy in what is their risk profile or actual risk, right? And then the LDL is underwhelming. That would be a perfect scenario to check ApoB. Yep.
For patients with HDL levels that are low, do you recommend anything else other than diet and lifestyle?
No, because it's all going to be lifestyle modification. There's still no pharmacological treatment, right? And I think the community has sort of given up on finding a drug that's going to increase HDL just because every time we tried it, it didn't pan out. So most of the time, it's just like a marker that we take advantage of, and I look for secondary causes. I like a third of the time, it's alcohol intake, to be honest. And then another big part of it is going to be the menopausal transition in women, and then a lot of it is going to be gradual. You'll see, like, if you trend it over the last 10 years for your patients, you'll see that it's been gradually going down. No, usually it can decrease it, yeah. I mean, it could work either way, but it's another opportunity for just to reassess their alcohol intake. Yep.
What are your thoughts about Redmond's pricing that Sprout, for example, which is very consistent?
I mean, if there's no strong reason they need to be on a statin, they can try all these, like, natural diet ways. It's just that if they're secondary prevention or high risk, I just be honest, they're not going to, the LDL reduction delta is not going to be high enough. So I'm always for, because a lot of times when they do these things, it sort of goes along with other good dietary changes. So I don't want to discourage that. So we have just a very honest conversation about the magnitude. So I say, like, for sure, you might drop it a couple points. Is that going to be enough of a magnitude to really get you to target? Unlikely. And but some patients, I'll meet them in the middle. If they're very like, I really want to try, I'm like, fine, I'll give you 8 weeks and we'll reassess, right? Again, in my more primary prevention cohort. Okay, last question. If it theoretically comes from what, sorry? I didn't hear the last part. So it's 150 and then what? If what comes back negative? Okay, yeah, but then you have to do the prevent risk score, right? And then figure out if they're high risk or not. Because if they're high risk or intermediate risk, then they should be on a statin to target LDL level less than 100. Borderline, you can have a conversation with them to start something or not, and low risk, they probably get a pass. So yeah, so that's exactly the right population to do the prevent risk score on. Great.